deep dive sessions that go beyond the standard presentations. Lively, interactive discussions designed to spark cross-disciplinary dialogue.
Hello, good morning. Junjie, are you going to start or should I be starting?
Yeah, you start first. You are the chairman. Yeah, introduce.
Oh, okay, sorry about that. Welcome to this year's Asia Heart Society meeting, and this session is particularly emphasis on the structural heart intervention topics, and we have. I'm one of the moderators. We have two more moderators, and can you put on the next? I am Michael Lee from Hong Kong. I'm currently a consultant cardiologist at Queen Elizabeth Hospital, Hong Kong, and also the chief medical executive of the Prime Heart, Lung, and Vascular Center in Hong Kong. And our other two moderators are, firstly, next one, please. Dr. Jing Chung Hu from Air Force Military Medical University of Tangdu Hospital. And the second one is from, next slide, is from the National Heart Center, Singapore, Dr. Yan Xiang Ki, who is also an experienced interventional cardiologist in Singapore. So we have a few topics to cover today. Can we have our program? Without further ado, I think I'm going to introduce the first speaker, TAVR for AR. Yes, TAVR for AR, what is new in 2026? Is going to be presented by Dr. Zhang Zhenjie from Nanjing First Hospital. He is a very experienced interventional cardiologist, a good friend of myself. He's a professor of medicine, serving as vice president of Nanjing First Hospital. He's doing both coronary and structural interventional procedures. So please, Junjie, can you start? Something new for AR this year.
Thank you, Michael. Thank you for your kind introduction. So it's my great honor to participate in this webinar. So today's topic is about the TAVI for pure AR, what's new in 2026. So you can see this is Oxford population cohort study from the UK. In this study, it's totally included 2,500 patients older than 65 years old without the VHD previously. Then they were undergoing the echo screens. Actually, result is quite amazing. You can see there is nearly 51% with new diagnosis with valvular heart disease. Among these patients, underdiagnosed moderate or severe valve disease found in 6% of this population. Among this population, more than 50% have aortic regurgitation. Nearly 80% aortic regurgitation patients with concomitant valve disease. Another cohort study is from the United States. This study is a prospective population cohort of 928 community volunteers without evidence of the valvular heart disease who received echo screens. The median age is 74 years old. Okay, you can see there were significant valvular heart disease present in 60%, predominantly with regurgitation lesions. You can see in terms of the aortic regurgitation, there was a 4.5%, significantly higher than aortic stenosis, 1.6%. Let's go back to our Asia regions. From the China DVD studies, it's the nationwide survey in the tertiary hospital. Actually, compared with isolated aortic stenosis, in terms of isolated AR, was more popular, 10% compared with the 5%. So this is another important review. Actually, you can see in terms of aortic regurgitation appears more common than reported in North American and the European society. In terms of the pathophysiology of the chronic severe AR, in the beginning, due to the volume and the pressure overload, I think the LV was gradually dilated, and also at this stage, the patient was symptom. With the disease developed without the optimal treating, like surgical valve replacement, the decompensated severe AR will develop associated with LV systolic dysfunction. At this stage, the patient will have symptoms of heart failures. So for untreated severe AR is always associated with high mortality, especially in those with NYHA 3 or 4 symptoms. So you can see in the right panel, actually for severe heart failure patient, you can see at 5 years follow-up, the mortality was up to 72%, extremely high. For mortality for patients not treated with aortic valve replacement was increased with great AR severity. At 2 years follow-up, mortality was 20% for patients with severe AR. So let's go to the guidelines. For ACC/AHA 2020 guideline, you can see what kind of patient with AR we should treat it with surgery. Actually, according to the guideline recommendation, the patient should have symptom of heart failure or wait for LV dysfunction like LVEF less than 50%, or with evidence of echo show severe LV remodeling or damage. So when to consider surgery in AR? Actually, you can see in this left panel, in this group treated with SAVA due to the aortic regurgitation. Actually, you can see compared with normal LV function without heart failures. A patient presented with heart failure, either New York Heart Association classification 2 or even 3 or 4, you can see at a 10-year follow-up, the best prognosis about the severe LV dysfunction. So in terms another parameter from the echo, you can see LVEF. Actually, although the guidelines of ACC/AHA recommended LVEF less than 50%, we should treat. But actually, you can see even the patient with LVEF of 55%, actually the mortality risk is increased nearly 2-fold. And also you can see the same parameter LVESDI. Actually, if the patient treated with weight and treated with this parameter more than 25, actually the mortality increased. So all these studies results show we should treat it earliest, not to wait. Actually, this is another big data from the United States. You can see all these 4,600 patients with severe AR treated with a SAVA procedure. Actually, you can still see 9% mortality at 1 year in patient receive SAVA, and compared with a 24% mortality at 1 year in patient left untreated, nearly 2.7-fold increase the mortality. And also you can see if the patient LVEF was severe, like less than 35%, was significantly worse compared with a normal LVEF. So in terms of this data, we can see actually if the patient have symptom with severe, actually you can, when we treated with SAVA, the long-term follow-up in terms mortality will be quite high. So what is the optimal times of the for the SAVA procedures for LV AR is we should know. So recently, last year's ESC 2025 upgraded the recommendation TAVI procedure for severe AR with a high risk for surgery due to nowadays we have a new device for especially dedicated AR valve for aortic regurgitation. So compared with AS, actually AR is very difficult when we use AS valve. Because compared with AS, there is no calcification, no fibrotic lesions. Actually, it's very difficult to angle it, which were associated with a high rate of the valve embolization and also with a high rate of pacemaker and also with a high rate of PVR after TAVI procedure. So in the last more than 10 years, actually, the pioneer have treated with AR with off-label use AS valve to save the patient. However, the result is suboptimal. Like the valve, the embolization, and also a valve in valve, and also the mortality is high compared with a regular TAVI procedure for AS. So this study is PESO international cohort, actually totally included 200 procedure use off-label use AS valve for pure AR. Actually, you can see in terms of the valve embolization ratio is up to 50%. Also, the valve in valve ratio is up to nearly 10%, and also of course mortality in hospital is up to 10%, quite high. In terms of technique success is only 80%. So this is a meta-analysis compared with dedicated valve versus off-label valve for pure ARs. You can see compared with dedicated valve, like previous last version of the Trans-Apex, a J valve or EN valve actually was associated with a lower rate of course mortality, valve embolization, and also the PPM compared with off-label use AS valve. However, in mainland China, actually, we have our domestic valve, like VitaFlow. Actually, our colleagues from Zhongshan, Shanghai Zhongshan Hospital, Dr. Pan Wenzhi and Professor Ge Junbo group team proposed the new technique named NCPI. Use this technique, actually, you can see compared with the conventional technique, when we use VitaFlow treated with pure AR, which was associated with a quite high rate of device success and extremely low rate of valve in valve. And the Song Guangyuan group from Anzheng also proposed a new classification named as ARURA classification. In terms of classification 1, 2, 3, actually, you can see when we use VitaFlow to treat this group, actually the device success was quite high, 91%, and also with a lower rate of pacemaker implantation. In terms of 30-day mortality was 0. In the recent 5 years, our group also used off-label VitaFlow self-expanding valve for the treatment of pure AR. This is a live case from our center to Salasic, 2023. Actually, this is a very elderly patient presented with heart failure, severe aortic regurgitation. Actually, the aneurysm diameter is 28, LVOT is 31, quite a large anatomic. And we use VitaFlow 30 millimeter with the oversize ratio 10% to treat this case. This is the procedure details. You can see with the echo and the X-ray guidelines, we precisely deployed valve at just at the 0 position at the aneurysm. Actually, the valve implantation is quite stable. This is result about the procedure TE for guidance of the valve deployment. You can see the valve position is quite good. It's a final result. This is also our live case from our center to TCT-AP 2024. Also, this is a severe AR with a high risk for surgery. You can see there is no any calcium. The ascending aorta was 33. The aneurysm diameter is 23, and the LVOT below the aneurysm is also 23. It's a degenerated aortic valve regurgitation. So according to the CT analysis, decision was to select the Vita flow 27 millimeter for this patient with the oversight ratio 12%. So the procedure we still with general anesthesia, with echo and the X-ray guidance to deploy the valve. With the rapid pacing, it's very stable. So this is the final result. Without the PVL, the valve function is very good. So this is another live case last year to solve valves. Also a severe AR patient with a heart failure. So without any calcium, so ascending aorta is 35. The diameter of aneurysm is 25, and the LVOT 4 millimeter below the aneurysm is 24. It's also a degenerated aortic valve regurgitation. So the ascending aorta is very associated with severe calcification. So for this case, we use computations similar to design the procedure according to the simulation result, which recommended 30 millimeter Vita flow for this particular case. And this model also recommendations valve implantation depth. So still, we follow the recommendation of the simulation mode. We selected 30 millimeter Vita flow for this particular case with oversight ratio 90%. This is a procedural detail. With the rapid pacing, we deployed the valve successfully with a high position. This is the final result. The valve deployed at the right position without any PVL. So actually, in 2021, Professor Chen Shaoliang and I organized the Seeding Air trial. This is the first randomized studies compared with TAVI procedure versus medicine therapy, GTM, for the treatment of high risk for surgery with heart failure and severe AR patients. Totally included 210 patients with a 1-to-1 ratio randomized either to TAVI procedure versus medicine therapy. So far we have a complete enrollment last year, and by the end of this year's May, we have completed a 1-year clinical follow-up result. So this year TCT will present our result. So we'll still go back to the guidelines. Last year, 2025, ESC upgraded guidelines. TAVI may be considered for the treatment of severe AR in symptomatic patients eligible for surgery according to the heart team, if the anatomy is suitable. So far we have actually in mainland China now we have three type of dedicated valve for severe AR. The first is the Yen valve triology AR system. With this angle device, which really can grasp in the valve for facilitate the valve deployment. Actually, this is the detailed procedure about this Yen valve. So Align AR study is a pivotal study for this dedicated device for AR. Actually, the 1-year result had also 2-year result had published in Lancet. So you can see it's a high risk, a moderate to high risk patient. The mean age is 79. SS score is 3.8. Nearly 60% presented with heart failure, classification 3 and 4. And also you can see the baseline LVEF is less than 55%. In terms of CT analysis, the aneurysm parameter is 80 millimeter. And thanks for this excellent dedicated device, actually the device success to 30 days was up to nearly 97%. And the amazing result in terms of procedure death was 0. But still there is some pity in terms of new pacemaker implantation. It's up to nearly 22%. However, for this new device, actually there was a learning curve. So this study was divided into 3 stages. You can see compared with the first 120 case, the last 60 case, actually, when the operator get a learning curve, actually, in terms of parameter endpoint and the new pacemaker implantation ratio was quite lower. So also statistics analysis shows RBBB and the valve size is an independent predictor of the pacemaker implantation. So this year's match, this device approved by FDA for the treatment of the symptomatic severe AR with high risk of surgery. So now there is another landmark study named as the ARTIST study is ongoing. So all included 1,000 patients presented with severe AR suitable for either SAVA or TAVR were randomized to SAVA and inner valve TAVR procedure. The primary endpoint was a 1-year composite endpoint, including death, and a symptomatic stroke and emergency cardiac hospitalizations. This study will be followed up to 10 years. And you can see in terms of the design of this study, in terms of the primary endpoint, it's a non-inferior design. However, for the key second endpoint, actually, which was designed to superior, the hypothesis is compared with a SAVA procedure, a TAVR procedure in terms of early safety endpoint will be superiority. So we will wait for this the landmark studies. So another important device is our domestic transfemoral J valve. It's also very smartly designed. There is 3 anchoring for the grasping the leaflet to stabilize the valve implantation. Actually, comparatively with the inner valve, the J valve has an even larger valve size for 33 millimeter, which can be used to treat the very large aneurysm. So far, this device has improved in mainland China. In the recent half years, we have treated severe AR with this static device more than 50 cases. Actually, quite a lot of cases, the aneurysm diameter is more than 30 millimeter. This is a key implantation steps. Is also stepwise, yeah. So in the last year TCT, Professor Wang Jian presented 2 years result of this J valve for the treatment for pure AR for the pre-market studies. So you can see the procedure outcome is quite good. There is no death in procedure deaths. In terms of the valve involved 3.9%. In terms of technical success was 94%. So at 1 year follow-up, of course, mortality was only 3.2. At 2 years is 6.3. In terms of pacemaker implantation, at 1 year is 12%. 2 years was 30%, quite low compared with inner valve. So this device is approved by National MMPA last year, September. Now commercially we can use device. In the last month in New York valve meetings, Professor Liu Xianbao and Hou Dongming, Wang Jian's group presented the early stage result about from the 789 patients after commercial approved. Actually, you can see this group, the patient mean age was 71%, 26% was females. Most operator was first time to use this gear valve transfemoral system. Actually, this is baseline CT analysis. Actually, 50% cases, the aneurysm dye parameter more than 85%. Actually, this is 30 days early stage result. The all-cause mortality was 1.2, valve-in-valve 2.2. And a very amazing result in terms of new pacemaker implantation ratio was only 1.5. You can see among these studies, majority, fourth cases was a large valve, was significantly higher than the pre-marketed studies. In terms of paravalve regurgitation is quite low. And also in the early stage after in-depth procedure, 30 days, you can see remodeling. So this is another very landmark studies, so named as ART studies. The design is very similar to the previous ART studies, also included low to moderate risk severe air patient suitable for TAVR or SAVR procedure, which was a randomized 1-to-1 ratio either to gear valve transfemoral TAVR procedure or SAVR procedures. The primary endpoint 1 year composite endpoint, and this study will follow up to 10 years. So another commercial valve just approved this year is our domestic Pioneer valve. Actually, this valve is also a dedicated valve, which also has a grasping ankle for the leaflet facilitated valve implantation. And the early Pioneer studies result published this year, last year in JACC Intervention. Actually, you can see the device success of 30 days was 97%. All-cause mortality was 2.7. The result is quite amazing. So let's take a conclusion. So dedicated device have shown excellent safety and effectiveness via transfer approach in short-term follow-up. So compared with off-label use THV system for AS, actually dedicated valve has a better acute performance. Our mainland domestic scholar have active explore indication, anatomic classification, and the implantation technique in off-label THV system. Of course, randomized study is needed to detect the progress of the benefit of a transfemoral TAVR as compared with SAVR for pure AR in low or moderate risk. Thanks for your attention.
Oh, thank you, Zhengjie. That's really a very comprehensive and excellent presentation. We can invite a few questions, but first of all, let me start with we can see that the prevalence of aortic regurgitation is a lot higher in China than the other parts of the world. Do you have a reason for this? Why we have so many AR patients in China?
I think in terms of our options, limited expansion, I think is a high prevalence of hypertensions. Actually, still not good under control. So majority, I think, in mainland China, the AR classification, I think the reason is under control hypertension. Yeah. So dilated ascending aorta resulting secondary aortic root enlargement resulting aortic regurgitations.
Okay. And then we see that you've been using VitalFlow very successfully. I was there during your live case in TCT-AP. I was chairing the session. Excellent result. But when you aim at high implant, even at 0, as proposed by Professor Ge, do you see a lot of pop-up of the valve, or you can see very stable position even at 0 or 1?
Actually, very good questions.
Yeah.
So in our limited progress, in our center, we have do more than 200 POR cases with VitalFlow. There is no pumping out after in that procedure, even with 0. Yeah. So our suggestion is anatomic analysis is very, very important. So when I use NCPI, actually, according to CT analysis, the level above the aneurysm, actually 2 or 3, 4 millimeter still can take action for the valve angling. So even 0 still can be very angry, very stable. Yeah. Wenzhi, you can comment.
Yes. I agree you to about the hyperlevance of the aortic. I agree is the uncontrolled the hypertension, and also it's no it's very seldom for the very pump up. I think it's very few, but some in some cases it pump out during the withdrawal of the delivery system. If you withdraw the delivery system too fast, maybe it can pull by the delivery system. So it will be very careful for us when we finally release the bed. Withdraw the delivery system, it will be very careful. Yeah.
It's very tempting to release fast because it's a motorized system.
Yeah.
So you just press the button and then you go all the way. So you have to like do it slowly with more control. Very good tip.
Yes.
Thank you. Any other questions?
Yeah, sir. Thank you, Dr. Zhang. It's a very good job that and show us some Chinese experience about using the AS device to deal with the AER patients. So my question is, what kind of anatomic characteristics to using the AS device to deal with the AER patient?
This is a key point about the patient selection. Actually, still high selection patient. The oversize ratio at this stage should at least 10% oversize ratio, 10% to 50%. First, this is the first point. Second point is algorithm. In terms of our seeding AI trial for the inclusion criteria, the aneurysm parameter compared with LVOT parameter should be the ratio between 95% and the 100%, which means should be tubal shape. And also after the get learning curve, I think Wenzhi is online. He also can comment later. The level above the aneurysm, 2 or 4 millimeter, actually is in our experience, I analysis every case for pure AR cases, 2 or 4 millimeter above the aneurysm still have the effect for the algorithm. So finally, taking summary, the algorithm should at least 5 millimeter. For this particular case, oversize ratio 10%, more than 10%, algorithm at least 5 millimeter, then can be selected. Then decision can be made use the Vita flow for treat this case. So the largest parameter for pure AR is 85 parameter for the Vita flow valve. Diameter is 25.
Okay, thanks.
27.
Yes, I agree.
So we basically use majority Yenna valve nowadays for pure AR. What's your thought? If you have a choice, would you use self-expanding valve for AS or dedicated valve like the Yenna valve, J valve, and the Pioneer valve?
Yeah, very good questions. Also, quite a lot of the overseas friends ask these questions. So far, for largest anatomy, like aneurysm parameter more than 85, up to even 100 millimeter, we have a new weapon, J valve, Yenna valve. But for smaller anatomic, like less than 82 or even 80 millimeter parameter of the aneurysm, we can still very safely treat it with Vita flow.
Okay, good tips. So thank you again. I think we need to move on. Thank you, Zhunjie. And can I invite Dr. Hu to introduce the next speaker? Yes.
Okay.
Thank you.
Okay, so it's my great honor to introduce the next speaker, Pan Wenzhi from the Zhongshan Hospital, Fudan University. Okay, his topic is about the Chinese expert consensus and the novel device development for TTVR. So let me introduce Pan Wenzhi shortly. So Dr. Pan Wenzhi is a chief physician at doctoral supervisor, director of the Structural Heart Disease Center, Heart Valve Center, Zhongshan Hospital, Fudan University Clinical Expertise Innovation. And he is a very famous structural heart disease doctors in China. So let's welcome Pan Wenzhi.
Okay, thanks, Professor, for introduction. I'm very pleased to have this lecture. Yeah, please, please show my slides. My topic is about the. Sorry, because I have some problem on my camera. I will close my camera. Oops. My is Chinese expert consensus of the TTVR. Next. Please. You know, the tricuspid regurgitation is one of the most common valvular heart disease and is increased with the age. So the mortality of the severe TR is also very high. It's as high as 10%. And in recent years, we know there are two devices approved by the FDA. One is the Evoke, and then is the TriClip. And we are very pleased. The TriClip also have approved in a few days ago in China. So we also have the commercial TTVR device. Maybe in the next few months we can use this device. Next. So based on this background, the structural heart disease group of the cardiology branch of the Chinese Medical Doctor Association commands expert consensus on the TTVR. And the purpose of the driving this consensus is to enhance the understanding of the TR and also the TTVR. Next. So the highlights of the consensus, the first is keeping up with the forefront of the field. It introduced the new classification of TR, also the latest device, and also the clinical results. And then it's clear and practical, and based on the domestic and international research and Chinese experience, and we are proposed a number of clinical recommendation, such as indication and also the manager's strategy. The third highlights the essentials, and we have the 10 core view points to help the reader quickly grasp the essence of the consensus. Yes. So the core view point one is the TR is one of the most common valvular heart disease, and it increases with the age. And TR is the independent predictors of the patient prognosis. And patient with TR complicated by the left side heart disease and pulmonary hypertension have the worst prognosis. And this is the new classification of TR. on the traditional classification, the TR have three levels tests, but it often variable. Or recent classification divide the tricuspid valve into 4 types. The type 1 is 3 leaflets. Type 2 have 2 leaflets. Type 3 have 4 leaflets. Next. And also we know the TR is the independent severe bad predictors of the process in a patient with TR. Is independent predictors of the worst prognosis. That's and also another studies have confirmed severe TR increase the patient's mortality. And also the annual mortality is different in different region for the TR. The isolated TR have and pulmonary TR have low mortality is 12 or 22. And while the patient have left-sided hereditary heart disease or left heart failure and pulmonary hypertension have the worst prognosis. And we also had a tri-score for the prediction of model for the secondary TR, and tri-score for the prediction of the surgery mortality for the TR. And we have do a survey of the echo data in our center. We found the severe TR maybe account for 1.4% in our echo databases. This shows the TR is very frequent in clinic patients in our center, also maybe in China. Next. So the co-build point 2 is TR can divide by mechanism into 4 major categories. Is pulmonary and ventricular secondary and atrial secondary and CIED related. So this is the TR classification. It can classify 4 types. The first one is primary or mixed TR. The second is the functional TR. It comprises ventricular secondary and atrial secondary TR. And also the CIED related TR is also common types and as the increase of the pacemaker increase. Next. So the co-build point 3 is the drug therapy is the basic treatment of the symptomatic TR and can improve the patient's symptoms. And the diuretics are the main medications, and other medication and non-pharmacologic treatment may be given according to the patient's different etiologies. Next. So this is the treatment of the TI patient. We should treat the patients first based his cause or his reason, and then consider the other treatment like intervention or surgery. So first we will be to find the reason and treat based on the reason of the TR, and then to do the interventions, the treatment for the patients. So the co-build point 4 is for patient with TR undergoing left-sided valve surgery. Concomitant tricuspid valve treatment is recommended. Isolated TR tricuspid surgery alone carry a relative high surgical risk, and the risk-benefit ratio need to be well carefully, especially in patients after left-side valvular surgery and also with poor right heart function. Next. And the guideline of ESC 2001 for the surgery and for the information of the TR. And then we have no new guideline 2000 is issued 2025. And then the recommendation is elevated. And for patients with the high risk for surgery, information for TR is class 2A in the 2021 guideline. Next. And also the surgery for the tricuspid valve for the TR is high. It's high to maybe it's to 10 to 20%. So it's no many surgery for the TR in USA, both in USA or in China. For the isolated tricuspid valve surgery is accounted just 5%. And so for patients with a high surgical risk, symptomatic and severe TR, TTVI will be performed at experienced centers. When selecting TTVI, the patient's local anatomic structure, disease severity, and surgical risk should be considered. This is the viewpoint 5. And for the viewpoint 6, for patients with high surgical risk, symptomatic and severe TR, TTVI will perform at this have yes, this is the viewpoint 6. TTVI is safe and effective in reducing the severity of TR and improving the patient's symptoms and quality of life. It's recommended to select device with evidence-based medical support based on a precise and comprehensive pre-operative process to achieve the best results. So it is the device, also the approach for the TTVI. It can classify by valve replacement and also the lift approximation, also and the lift and annuloplasty. In China, two device, K-clip and loose valve, is I think is creative device. Also, it has the intonations effect. So I introduced these two devices. The first one is the K-clips. It's a normal design annular plastics device. It's similar to the surgery, case surgery, to strengthen the annulus and to as results to reduce the TR, and it's implanted by the transjugular, and it's approved by NMPA in March 2025. That's so this is the 1 year's results from the TriStar study is leading by our team. It's also a multi-center study performed in China. This 1 year results has confirmed the safety and the effectiveness of the K-clip. Next. So you can see the 80% TR reduction decreases to the moderate or low at 1 year, and 9,500 patients achieve more than 1 TR reduction. So the I think is the effects is similar to the TT. Okay, next. So the capability also have the transformer additions. You know, the first additions of the calculator is transjacular, but the second additions, the new one is can be done by transformer, and so it's more easier or more friendly to our doctor. Next. Also, a normal creative device for TTVR is the transjacular TTVR system is loose valve plus, and also do the multi-center clinical trials leading by our team. This TTVR device, and next, and it has do several clinical trials. This chapter 2 study has finished the 1 year follow-up. Okay, you can see the major composite events is low. The stroke is 2%, and then the pacemaker implantation is just 2%. This is superior to the evoke. Evoke the pacemaker implantation rate may be as high as 15%, but for the loose valve, the pacemaker rate just 2%. This is very good results. And also the all-cause mortality is 4.5 at 1 year. This also low as compared with the similar device, just like Evoke. So the extent of complication events is just 15.5%. So the 6 months, this is the CE results for loose valve. It also have achieved good results. The most point impressive point is the last annulus. You can see, the over 75 the enrollments utilize the bell size after 65. So this bell can suitable for patient with large annulus, and this is the patient maybe no suitable for the Evoke, but for this large annulus patient, it can used by the loose valve. So this is the superiority of this valve. Next. And our patient in the different states, we can use different device. For the early patient, we can use the TTVR or the TT device, but for the patient on the advanced stage, we can use the TTVR replacement like the loose valve or like Evoke, and also we can use the carway device is implanted in the superior or inferior cable vein and to improve the patient's symptoms. This the schematic for the patient's device selection. Yes. So the COVID.7 is we commented the clinical study of the TTVR device use the endpoints focus of the improving patient's symptoms and quality of life. Why also we should paying attention to important short-term and long-term safety and efficacy indicators such as survival, heart failure, with hospitalization and the degree of the regularization improvement. And also we recommended to use the TVAC criteria to standardize the definition of the clinical study at the points. And then this the trimunate trial have confirmed the efficacy of the TTR in the patient was randomly assigned 1:1 ratio to TTR or the medical. It confirmed it can improve the patient's KCQQ score and the patient's symptoms. Next. The transient study also confirmed it can improve patient's symptoms and improve patient health status. Next. So for the viewpoint 8, before TTR is necessary to understanding the well-related anatomic feature and pathogenesis and to perform invasive clinical imaging assessment. And we pay attention to the pulmonary artery pressure and right heart function and left heart function, also a comprehensive assessment of the patient to determine whether the patient is suitable for TTVI. And also the clinical assessment includes the KCQQ and the imaging assessment includes the echocardiography and CT. And CT is very important for the replacement device, and echocardiography is important for the repair device. Okay. Next, this is the clinical symptoms assessment and include the NYH function, 6-minute walk test, KCQ score, and also the medication. And the score 2 is it can use for the patient's surgery risk assessment, and also the STS scores can use, and to include a separate module for the tricuspid surgery. And TriScore is most widely used for the patient's tricuspid valve surgery. Okay, next. So this imaging assessment, CT is important for the replacement device, and for TTR, TT also for the any plastic device. TT is the key part of the operation imaging evaluation. And we are note the pulmonary artery pressure assess is also very, very important. With the patient, if the patient have pulmonary hypertension, we recommend we should treat the pulmonary hypertension first, then consider the TTVI. So also we should consider the patient's right ventricle function. We have one new index that is called RVPA carbon ratio. This is important or very good indicator for pre-operative assessment. Next, so this the Chinese export consensus of the TTVR tricuspid regression is the indication of the patient for TTR includes the first, the patient should have the clinical symptoms and including the symptoms of the right heart failure, or also the dyspnea exertion. And the patients should, in the absence of severe pulmonary hypertension or right heart failure, the PASP should less than 65, and the test should less than 12, and the left ventricle function is no severely impaired. The AVEF should be larger than 45, and it should be anatomic suitable and is high risk for surgery or unsuitable for surgical treatment. I know in recently, the Europe experts also issued one consensus of the TVT. I have read the consensus. I thought they suggest indication for TTVI is similar like this Chinese export consensus. So it is so I think our consensus, although is issued 2 years ago, but the viewpoint, especially the recommendation for the indication for TTVI is I think is also suitable for current time. Next. So the viewpoint 10, TTVI is currently in its early stage of the development. Suitable patients should be sedated, and the surgical teams should undergo rigorous and systematic training to reduce the occurrence of the complications. So the heart team is important for TTVI. Next. The heart team includes the surgery and intervention and occurrence and cardiology, and also the anesthesia. So this is my the contents of my lecture. Thank you very much.
Okay, thanks, Dr. Pan Wenzhi. Very excellent speech about the Chinese expert consensus on transcatheter treatment for of TR. And so we know that you are very good at the structural heart disease, and so I noticed that you recently did a very good job about the MetroClip treatment. So you were using the two MetroClip devices to treat with the MVR. So can you introduce some experience about the about this work compared with the one device? So can you introduce us some experience?
Yes, I think yes, the question is very good, and also I think maybe it's interesting for many doctors. In this case, the patient has a detached mitral ruin. After the surgery, the ruin has detached, so the mitral regurgitation will occur. So when we use one device, one system to do the MTR, it had no space. The delivery system or the clip we engage with the ruin. So I think I think many times how to complete this patient. So I have one case in maybe in France. One doctor have used two system deliver system to do the MTR, but he has no use to do the case like this. So I think we also can use these methods. One delivery system is to move. We can because you can see when we use the mitral delivery system, it helps a lot of we can adjust the delivery system, the clip. It can I think also the force is strong. When we adjust the delivery system, we can use the delivery system to push away the rain. So we use those. We have the space to let another delivery system to do the tier, and we put the delivery system. One is from the left femoral vein, and another for the right femoral vein, and we punch the atrial septum. One is high, one is low. The first one is maybe is 4.4 millimeter or 4 centimeter, and another one is 5 millimeter. And I use the two delivery system to do the proceeding. So thank for your question.
Okay, thanks, Dr. Pan. It's a very good work, and so we're looking forward the further results. Okay, thank you. So the next moderator.
Yeah, maybe shall we move on?
Okay.
Yan, would
Thank
you like
you.
to intro? Thank you, Wen Zi.
Thank
Would
you.
you like to
Okay,
introduce
please. Thank
the
you.
next speaker? Thank
Okay.
you. Yan Shan, can you introduce? Yeah, it's your turn.
Of course, it's a pleasure to introduce Dr. Ganesan Karthikeyan. He's going to speak to us on rheumatic heart disease, what we've learned so far. So, Dr. Ganesan.
Thank you. Am I allowed to share my screen here?
Can we allow Dr. Ganesan to share his screen, please?
Are you able to see my screen?
Yes, we can.
Yes, looks good.
Thank you. First of all, thank you for having me as a speaker here. It's a great pleasure and a privilege. I'm just wondering if this talk fits in the structural heart disease session at all or not, but I'm not going to be talking about PTMs, balloon metal or anything else. This is just about rheumatic heart disease, that some of the research that we've been doing over the years. So I just want you to be a little patient here, because I think others may have expected more structural talk. So this is just to give you an idea of what the burden of rheumatic heart disease is. This is data from the Global Burden of Disease. I believe China doesn't have so much of rheumatic heart disease, just like some parts of India don't have so much rheumatic heart disease. In fact, it may interest you to know that when we initially were starting the Invictus trial, which was the rivaroxaban versus VKA trial, China was one of our countries, but we could not recruit sufficiently large number of patients, so we had to drop China. So in any case, so we can see that rheumatic heart disease remains quite common in some of the poorer countries and poorer parts of some of the richer countries. But it's heartening to see that there is a lot of research now happening. So if you see the first earlier peak here is when the disease was quite common in North America and Europe. So after that, research had dropped quite considerably. But now again, there is an interest in rheumatic heart disease. And most of this research is done by people living in countries which are RHD endemic. So that is a good thing. So the question that I've been asked is to talk about what's new in rheumatic heart disease. So I think that there are three big changes that have happened. So first of all, there is now better data on disease burden. And I'm not talking about the global burden of disease data, which is largely modeling data, but talking about registries and other registers which have been implemented in many countries. So we have better data on disease burden. We also have better data on outcomes because now we have prospective data which looks at outcomes in these patients, and this is also multi-country data, so that is also useful. And we also now have better data on preventing progression. So I'll just touch briefly upon each of these points as we go along. And so the idea of looking at the data for rheumatic heart disease is how do we improve outcomes in these patients? And so if you have to just look at what the current status is, I've just taken South Asia as an example because the population, the prevalence of rheumatic heart disease. So if you see RHD-related deaths are falling, and they are falling probably at about annual rate of 2%. And if you see at the bottom, there is the high income groups where the mortality due to RHD is quite low. So we are still not there. I mean, there is still quite a lot of mortality because of rheumatic heart disease in South Asia at this point in time. Now, we know that if we have to do something, if we have to reduce something, we can't do business as usual. We need to change things. So how do we change the trajectory? So what do we need actually? So this is again from the GBD Foresight data. So you can actually look at the forecast. And this is again South Asia and high income countries. So what we are doing now, what we are seeing now is a 2% reduction, but what we need is a 4% reduction. So if we can get a 4% reduction, maybe by 2040, we'll be at high income levels of mortality for rheumatic heart disease. So how do we do this? So the first thing to understand is what is important in rheumatic heart disease research. Traditionally, RHD research has come from Western countries where the disease was not so endemic, but it was more of an epidemic in the earlier stages of in the 50s and 60s. Our ideas of rheumatic heart disease have been shaped by those data. But I think we need more data from currently endemic countries. And so this is something that we did several years ago. This is the Remedy Registry, which was done in Africa and India. So what we found was the mortality due to symptomatic RHD was quite high. So it was about 8.5% per year. And the other important thing that we think a lot about when we talk about rheumatic heart disease is the risk of stroke. And we found that the risk of stroke was not so high. That's primarily because these patients are much younger than the patients who are with AF in or other countries, in Western countries. So this is some insight that we had in the beginning. However, our first randomized trial was a trial of stroke prevention. This is the Invictus trial. And we tested rivaroxaban versus VK. So the idea, we had initially powered this trial for a reduction in stroke, but as we went along, we realized that the stroke rates were quite low. It was just less than about 1%. So we were underpowered, and so we had to change the outcome in the middle of the trial, and the primary outcome was changed with, of course, we were blinded to the data, but we made it an all-cause mortality outcome along with stroke. And we showed that, to our surprise, that VK reduced all-cause mortality in these patients. So it reduced the risk of death. But the important takeaway from this trial, again, was that while the rates of death were about 8% per year, the rates of stroke was just about 1% per year. And these are older patients. These are average age of about 50, quite atypical for rheumatic heart disease patients. And they all had AF, and about 20% had high CHA2DS2-VASc scores as well. So these are not low-risk patients, but the risk of stroke, nevertheless, was just about 1%. This is also from the large Invictus registry, which is about nearly 14,000 patients, and this is a multi-country registry, about 24 countries around the world. Again, we showed that the risk of death is quite high, and the risk of stroke is quite low, and most of the death is because of heart failure. So these are things which we probably knew intuitively, but then because of the type of patients that are seen in the West, we tended to think that stroke is more important than mortality. But this has now become well established that mortality is the thing that we need to talk about. And how do we improve mortality then? And this is something again from the old remedy registry, where we had a group of countries which were low income, upper middle income, and lower middle income. So when we looked at mortality across these countries, we found a quite straight gradation, and with the low income countries having the highest mortality. And possibly because these are not these are data at baseline. And if you see that the uptake of interventions, valvuloplasty and surgery was much higher in the higher income countries, upper middle income countries. So this could be one of the reasons, is what we thought. And so we looked at this in the Invictus registry. And here you can see that factors that were associated with mortality, if valvuloplasty or valve surgery were done during follow-up, they considerably reduced the risk of death in these patients. And this makes sense. So this is something which we need to provide to patients who are symptomatic with rheumatic heart disease. Now, even in the Invictus registry, only about just below 10% of people underwent any sort of valvuloplasty or valve surgery during follow-up, which is about a 3-year follow-up. And this is despite the fact that all of them were symptomatic. So there is an access issue as well. So in the meantime, when people are waiting for surgery, what do we do? So we recently completed this randomized trial of digoxin in patients with symptomatic rheumatic heart disease, and we showed that digoxin has a benefit in terms of reducing worsening heart failure events. And it does not affect mortality. I mean, there is always been this concern that digoxin increases mortality, and despite the fact that the large DIG trial did not show any signal of increased mortality. And we were again able to show that there was no increase in mortality, but digoxin reduced heart failure events. So this is a useful drug to have because it's inexpensive and it's widely available. The other part of treatment of rheumatic heart disease is how do we prevent progression? So traditionally, people have been using secondary prevention using benzathine, penicillin, or any of the other antibiotics. Now, the only data that we have that penicillin reduces progression is in patients who have screening detected rheumatic heart disease. So this is data from the GOLD trial where we had recruited patients from Uganda. Not patients, these are school children who were screened to have and found to have definite RHD or borderline RHD by echocardiographic criteria. So these are not even mild disease, they are trivial disease. So here we were able to show that benzathine penicillin reduces progression, echocardiographic progression. This is just 2-year data, so it's not clinical progression, but it's echocardiographic progression. But however, these results may not be applicable to the rest of the world because there was excellent adherence to benzathine penicillin here because the adherence was something like 99%. It is a trial-based adherence, so there was a lot of effort put into people getting their doses of benzathine penicillin. That we know that that's not possible in the real world. Adherence is typically about 30%. So we don't know whether this, and besides, these are all echocardiographic progression. We don't know when they will progress to clinical or if benzathine penicillin will reduce progression to clinical RHD. We don't know that yet. So what we have is the data from the other registries where we can look at whether secondary prophylaxis really improves progression or not. So this is data from the REMEDY study. Again, clearly, patients who have significant valve disease, perhaps benzathine penicillin doesn't have a role, although the WHO recommends that everybody should get lifelong benzathine penicillin if they have a rheumatic heart disease, symptomatic rheumatic heart disease. I don't think that will be useful, but it's difficult to say no until we have data for that. I think in the meantime, we need to talk about what else can lead to progression? So this is something which I don't know, physicians involved in treating rheumatic heart disease would have noted. Rheumatic heart disease is essentially a mitral valve disease. Every single patient with rheumatic heart disease has mitral valve involvement, whether it's mild or moderate or steep. And if you see the gradation of involvement of the different valves, you will notice that the mitral is the most common, and then followed by the aortic, the tricuspid, and then finally the pulmonary. Now, this is something which we all know intuitively. So if you look at what it is that differentiates the valves, it is the closing pressure against the valve, which is the pressure exerted on a closed valve. So if you see the mitral valve, that pressure is highest because it is the LV systolic minus the left atrial pressure that is keeping the valve, that the valve has to resist. And similarly, the aortic valve, it is a little lower because it is the aortic diastolic pressure against the LV and diastolic pressure. And similarly, the tricuspid is much lower and the pulmonary is almost quite low. So there is a clear preference for involvement of the valves in rheumatic heart disease. So it is plausible that immune injury is necessary, but it is not sufficient to produce disease. So hemodynamics may play a role. So the second important observation supporting this concept is this is a paper that this is one of the 2 or 3 case reports where patients who have corrected transposition of the great arteries, when they develop acute rheumatic fever, they develop tricuspid stenosis, because that is the valve which is on the left side, which is associated with it, which is exposed to the higher pressures. So, and also we know that TS can develop in patients who have rheumatic heart disease and severe pulmonary arterial hypertension. So there is hemodynamics involved as well. It's not just immune injury. And the final bit of evidence for this is a report from our hospital many years ago from the surgeons who did a Ross procedure. They used to do Ross procedures for young patients with severe aortic regurgitation due to rheumatic heart disease. Now, they used to put the normal pulmonary valve in these patients, the autologous pulmonary valve. And if you see, when they compared people with non-rheumatic aortic valve disease who underwent Ross versus the rheumatic ones, there was a significant rate of early degeneration. So, and many of these, once they explanted these valves, they found that there were lesions suggestive of rheumatic pathology on histopathology. And very few patients had actual acute rheumatic fever in these cohorts. So these 3 important points suggest possibly that hemodynamics also plays a role. And when we looked at the basic science of it, so there is clearly a role for TGF-beta in vascular interstitial cell remodeling. And once vascular cells, endothelial cells are exposed to stresses, TGF-beta is overexpressed in these patients. And there is also a lot of data sporadically published from both China and Korea and some other countries as well. So genetic polymorphisms of the TGF-beta gene are more prevalent in patients with rheumatic heart disease. And this is being reported both from China and also from Korea. And there is also evidence from histopathologic studies that TGF-beta is overexposed in the subendothelial stroma of valvular leaflets. So there is a clear role for hemodynamics and possibly mediation through TGF-beta. So, and we also did a small study where we looked at rheumatic mitral valves and 5 control valves, and we also showed that TGF-beta overexpression happened. So the idea is that perhaps we've been giving unnecessarily benzathine penicillin for people who have established rheumatic heart disease. I'm not talking about the people who have mild or trivial valve disease. So autoimmune injury happens during acute rheumatic fever. But at that point in time, epigenetic priming of TGF-beta signaling occurs in all valves. But only the valves which are exposed to the high transvalvular pressure gradient, like the mitral valve, aortic valve, and left-sided tricuspid valve, develop valve lesions. And the low pressure valves don't develop unless they are exposed to high pressures, like if the pulmonary valve is transposed to the aortic position in a Ross procedure, or if tricuspid valve is exposed to high pulmonary arterial pressures. So this is something which we proposed a few years ago, and what we thought was the implication is that if we can modulate TGF-beta signaling, and we know that losartan is being used for TGF-beta signaling modulation, and we are now proceeded to do a trial of losartan in patients with rheumatic heart disease to see if it halts progression or at least retards progression. So I think I'm going to stop here because there's nothing much else I can talk about. So what I would think is that if we think that rheumatic heart disease is the problem, then the idea would be to do randomized trials to test existing and novel treatments to improve outcomes. Because rheumatic heart disease, the DIGE RST trial, which we just completed, is the only trial which was designed to improve outcomes, because there are no real proven heart failure treatments in patients with rheumatic heart disease. So we've just been using everything empirically. So we need to actually develop the evidence. And we have been stuck on original mechanisms, but we don't know whether they really contribute. And we need to be open to alternative mechanisms and novel approaches to treatment if we have to reduce the mortality. And now there are many more tools that we can use, and we can understand pathogenesis and identify treatment targets. So all this research has to happen, at least in RHD endemic countries. And of course, this cannot be done without international collaboration, because many countries in Africa are still quite dependent on people from India and China and others to help them with doing their research and medicines and everything else. So I think what we've been proposing is to do an international registry of ARF and RHD to serve as a platform for basic science and clinical research. So registry-based randomized trials and the like. So we've been working on this for some time, but we haven't secured the funding for it. But ultimately, this is the way forward. So I'm going to close here, but I just wanted to thank the BMJ, because I think the BMJ contacted the organizers of this conference so that I could speak here. So I'm the editor of the BMJ Open Heart, which has an impact factor of 3.1, and it's an open access journal. And we are quite quick in turnaround times and other things. And so I'm sure many of our Chinese colleagues know about the journal, because quite a few of them publish in our journal. So this is just to give you some information about the journal. Thank you very much.
Thank you so much, Prof. Ganesan. That was a masterclass and overview of rheumatic heart disease over the past 20 years. I think it's very pragmatic in the local APAC region to actually discuss this issue. And I have one simple question to Prof. Ganesan. In our day-to-day practice, we do see patients with rheumatic heart disease, mild or no mitral stenosis, who have atrial fibrillation. And in this group of patients, based on your experience in the Invictus trial and so forth, what is your choice of anticoagulation in this group of patients? Prof?
So thank you for that question. So we typically don't see patients who have mild mitral stenosis with atrial fibrillation. It's typically those who have at least moderate or severe mitral stenosis. So the idea, what I'm trying to say is that the reason why we found VKAs to be superior to rivaroxaban was possibly because of performance bias, because in the trial, we saw the VKA patients every month because they had to have their INRs modulated, whereas the rivaroxaban patient was seen every 6 months when they came to collect their 6-monthly medicines. So possibly that was the reason why patients had better outcomes in the VKA arm. So the interpretation for me is that in patients who have symptomatic rheumatic heart disease who will be better monitored and they will have better outcomes. The other thing that we did not emphasize too much in the paper, in the Invictus paper, it's not there, it's just buried somewhere, is that even though the trial was underpowered for stroke outcomes, the risk of stroke was more with rivaroxaban. So rivaroxaban is not such a good drug for perhaps patients who have severe mitral obstruction because there's so much more going on. There's more stasis, there's more inflammation in the walls and so many other things. So contact activation is not sufficient. Inhibition of contact activation is not sufficient because that's what rivaroxaban does, right? So we need a more broad-based anticoagulant for preventing stroke and rheumatic heart disease. So I would suggest that everybody who has symptomatic rheumatic heart disease with significant mitral stenosis should get VKAs rather than a DOAC.
Over to you, Dr. Lee and Prof. Fu.
Yes, excellent presentation. Just a very quick question. Although we are not talking about PTMC as you mentioned before, but when we come to intervention, like for middle-aged patients, they are actually symptomatic enough to have interventions. What's your recommendation nowadays? PTMC or go for mitral valve replacement?
So if you see the largest data that we have is from the Invictus registry, which is nearly about 14,000 patients. So in that, our experience is that even in our clinical experience, it's that most of our patients are now slightly older. They are in the 40s. And many of them have significantly calcific valves as well. But we are not very, so we tend to do PTMC more often than surgery because we know that these are younger patients, and even if we did surgery, we have this problem of not poor adherence to VK, and they may develop valve thrombosis. A lot of the work that we have done also shows that people tend to develop valve thrombosis when they don't adhere to VK. So we prefer to do PTMC, even if we don't get excellent results. Of course, if the valve is pliable and everything else, that is PTMC is the treatment of choice. But in older patients who have slightly bad valves, we still go ahead and do PTMC as a first step. And so they get another 4 or 5 years of life, and then after that, they can go for surgery. So that's been our approach. It's not evidence-based, but that's a practical thing that we do.
Great. Thank you again. Thank you, Ganesen. We need to move on. Thank you.
Thank you very much.
Thank you. Our last speaker would be Professor Xu Kai. Professor Xu Kai is from the General Hospital of the Northern Theater Command of the Chinese People's Liberation Army. And he is going to talk to us on a novel transcatheter edge-to-edge mitral repair system from China. Please go ahead, Xu Kai.
Okay, thank you, Michael, for your introduction. It's my dear Professor Yang Ken and all experts online, and it's my great honor to present a lecture about a domestic device for ampere. Okay.
Yes, there you go.
Okay, thank you. The device I want to introduce is from Senji Medical, and it's called Qilin device. It looks like a mitral clip, but there is a difference between the two devices. So it's mechanical locking and independent grasping, like G4, and it's multi-plane steering, and similarly have whole clip size based on the width and the length of the clip. When we look at the structure of this device, we can find some difference between this device and other device, especially between the for the Abbott mitral clip. First, the line connected to the gripper is different. For this device, the line is connected to the tail of the gripper, so it can avoid entanglement between the device and the leaflet and caudals. And also, when you look at the graphing area, it's larger for this device compared with other device. So the advantage of this point is peak stress on the leaflet is reduced significantly. So it's more safe for the procedure. So far, 3 separate studies have been finished and published. It's a film study and study in the patients with FMR and the patients with DMR and sorry. And the 1 year follow-up data of DMR and the 2 year follow-up of FMR were present and Euro PCR already. So today I want to introduce those 3 studies one by one. First, at the beginning, Dr. Han launched the film study. Actually, at that time, most centers in China is on learning curve for the MTR. So we have a lot of discussion about the protocol for this film study. So totally around 18 patients were enrolled, and both patients with DMR and FMR were enrolled in this study. And primary endpoints is procedure technique success immediately after procedure. And we also have other secondary endpoints. For example, the all-cause mortality at 30 days, and the incident of severe adverse events and device success. Totally 6 centers participant this film study. At the very beginning, we are very have very severe, very strict criteria for the inclusion and exclusion. We include patients with ejection fraction more than 30, and also patients left ventricular and systolic diameter less than 60 millimeters. So compare with COAP or other studies, the criteria is very strict. And for the anatomy inclusion criteria, we focus on the A2P2 regurgitation, and also have actually those patients are the green zone patients for the MTR. So this is the baseline information for the film study. Average age is around 75, and more than 80% of patients have heart function class 3, and also about half patients have a history of coronary artery disease. We have 6 DMR patients and 12 FMR patients. All the patients has high STI scores. For the technical success rate is 100%, and no deaths at 30 days, and the device and the procedure success rate is 88%. So this is the immediate procedure outcome and the major adverse events at the 30 days. We can see mean number of clip used were 1.17, and when we look at device time, is quite long. As I mentioned previously, the many centers is at the learning curve. So for the repeated intervention, only 1 patient have this MAE. Also, we can see more patients use the wide and long clip. So for the patients' mitral regurgitation, they change a lot at 30 days compared with baseline. Most patients have regurgitation less than grade 2, and also the heart function improved quite a lot. So this film study has shown the preliminary safety and efficacy of this the MAX device in the MTR procedures. So next, I want to introduce the the study for the patients with function MR. And also, I want to report the 2-year result of these single arm studies. This is a study design, and more than 125 patients were enrolled. Also, the primary endpoint were deaths from any cause of hospitalization for heart failure within 12 months, very similar as the COAP trial. And also, all the patients already have adequate treated for the coronary artery disease, left dysfunction, before the enrollment, and different from the FAME study, ejection fraction was more than 20% in this FAME study. So this is the patient flow. Totally 125 patients were enrolled and implanted with the device, and the average age were 65, and most patients have heart function grade 3 or grade 4, and the average ejection fraction were 41%. So this is the procedure results. Technical success rate was 100%, and the device time 61 minutes, less than the FAME study. Similarly, most patients have the device with a wide and long design. So this is the safety endpoints at 12 months. 5 patients died, and 6 patients have stroke. 1 patient have myocardial infarction. Only 1 patient has a single leaflet device attachment, and the total MACE rate was 10%. This is the Kaplan-Meier curve for the primary endpoints. So freedom from all-cause deaths or heart failure hospitalization were 78% at 24 months. So for the mitral regurgitation, it had been controlled quite a while at 24 months. Most of it has regurgitation less than 2 plus. And for the echo parameter, we can see the left ventricle diameter decrease significantly from the baseline. This is a comparison between our study with other COAP. Actually, the patient enrollment criteria were different. We cannot compare directly, but for the main MAE is 78% in our study. So this study showed the safety and efficacy of this DMAX device in the patients with function MR. So next, I want to show the results of the patients with DMR. It's also the multi-center study, single arm. This is the study design. Also, we have independent ICO collab. It's a single arm study. Around 120 patients were enrolled, and the primary endpoints were a composite of freedom from all-cause surgery for mitral valve dysfunction or residual MR more than 2 plus within 12 months. Also, we have other secondary endpoints and safety endpoints. So similar as the FAME study, we focus on the regurgitation at mainly within the A2P2 area, and also ejection fraction more than 20%. And also the anatomy inclusion criteria very strict. It's mitral prolapse area-wise less than 50, and the height prolapse height less than 10 millimeter. This is the patient flow for this study. We look at the average age is 71 years, and those patients has very high STI score for mitral surgery, and most patients have heart function 3 or 4. This is the echocardiography echo baseline information. So more than 80% have MR 4 plus, and the average ejection fraction is 63%. So for the technical success rate is 100%, and the device implantation time were 74 minutes. And when you look at the number of devices used in per patients, it's more. There are more clips used in this study compared with FAME and patients with FMR. So around 40% patients have 2 clips, and 3 patients has 3 clips. And similarly, more clip, wide and long clip were used in this study. So this is the Kaplan-Meier for the primary endpoints. Also, this is OPEC study for the historic performance goal. We set is 60%. Also, our primary endpoints showed very good clinical success rate, and based on the data of these DMR patients, China FDA approved this device at the beginning of this year. So this is the patient's registration and also the heart function both improved quite a lot compared with the baseline. This is the left ventricle diameter, and KCCQ score also improved significantly compared with baseline. For the safety endpoints, we can see at 12 months, there's 30 patients has MAE, 9 patients died, and 3 patients had surgery for mitral valve dysfunction, and device-related complications were 7.5%. So based on this study, this also demonstrated this device has favorable safety and efficacy profile for the treatment of the patients with DMR. Also, I'd like to show a case with DMR by this device. It's 76 years old male. STX score was 88.6, and the patient has posterior mitral leaflet prolapse, and the ejection fraction is 57%. It's baseline echo, so very severe regurgitation and the P2 prolapse. And our puncture height were 4.13 centimeters. This is the use of. I just want to show how it's look at the base at the fluoro by the fluoro and by the echo. So this is the alignment of the device for coapsion line. So this is the for the grasping of anterior and posterior leaflet. First, we use simultaneous grasping, but it failed, so we used the independent capture of the post leaflet, and the final result was very good. Also, this is the immediate result, and also the 1-year follow-up. So thank you for your attention.
Very nice presentation, Shikai. And very, I would say, a promising device to use. You mentioned that the device has received NMPA approval. Am I right?
Yes, this year, at the beginning of this year.
All right. For both DMR and FMR?
Only for DMR. Yeah.
So when do you expect we can use the device? When do you expect you will be
I think
available?
maybe very soon. I think very soon. Even in Hong Kong.
Yes. Because we have quite a lot of patients. And this device is for mitral. Can it be used for the tricuspid as well?
So far, no. But in the future, the company also they have planned to have they already launched the tier study. Not by this but very similar device. Platform is same, but the other device.
And you also mentioned the limit is the gap is 15 millimeter. Yeah, well, if it is more than 15, do you still can we still try with this device?
Yeah, actually, the late phase of the study, we try to use in the yellow zone patients or very challenging case. I think it's very promising. Also very success in those patients, as you mentioned. Thank you.
Yeah, very good. Very promising device. Any more questions? I think it's almost time for us to end this session. Yes, thank you. Thank you, Shikai.
Thank you. Also.
Let me wrap up this session. It's almost time. Thank you again for attending this session on the Asian Heart Society Research Summit. This session is mainly on the guidelines and proceedings of valvular diseases. As you can actually see that we've covered from severe aortic regurgitation, the novel devices, to TTVI, transcatheter tricuspid valve intervention, and then touch on the rheumatic heart disease as well, and then end up with this China locally made transcatheter mitral valve repair system. So thank you again for staying with us. Thank you, my co-chair today, Dr. Hu and Dr. Key from Singapore, and the panelists and the speakers. Hope we can continue with this momentum to push forward interventions in valvular heart disease in the future. Hope we can be again in another session, and at least next year we will have a similar session again. Thank you. Have a good Sunday.
Thank you. Goodbye.
Bye.
Thank you. Bye. Bye.
Dear colleague, dear friends, as the president of the Asian Heart Society, I'm thrilled to announce that the Asian Heart Society Research Summit 2026 will take